unfortunately be less likely to jump in and invite that child again, right? But if they were to walk up to a different child and ask that child to play, and that child said yes, and they had a great time at recess for 20 minutes, they're more likely to ask that friend again. So again, we're trying to think about reinforcing those behaviors we want to see more of, and then not reinforcing anything that we want to see less of. So our rules of reinforcement, we want to avoid reinforcing behaviors we don't want. So our classic example is the kid that goes to Kroger and really wants a candy bar, right? And you say no, and they throw a tantrum for the candy bar. Well, what usually happens is the parent is gonna get embarrassed. They're causing a scene in Kroger. It's upsetting. They have to get out there. They've got somewhere to be. So they might just hand the kid the candy bar and say, okay, like, please be quiet. And then that stops the child from crying, right? But that reinforced the behavior that we want to see less of, right? So now that child has learned, okay, if I cry and throw a fit in the candy store, I will get the candy bar. So that's kind of the process that we're trying to avoid. When we do reinforce kids, we want to deliver that reinforcement immediately. So most of us do not get paid at the end of the entire year, right? It would be hard to keep going if you worked for 365 days and then finally got a paycheck, right? Instead, we get that paycheck every 2 weeks to remind us, hey, you're doing a good job. You're still getting reinforced for that. But for children, they have an even shorter attention span, right? So they really need that reinforcement as immediately as possible so that they can draw that connection between the behavior that they engaged in and the reward that they got. So for some kids, if they did something awesome at 10 a.m. and they get a reward that night at 5 p.m., they can't necessarily make that connection that it was what they did at 10 a.m. that their parents were really excited about that got them the reward. So we want to be as close as possible. Yes, you sat and listened for a couple of minutes like I asked. Here's a couple of fruit snacks like we talked about, kind of thing. Reinforcement is also unique to each child. So a lot of times, I know it can be hard. Parents think about like, oh, I want them to be reinforced by certain things. Like I want them to be intrinsically motivated, or I want them to find it reinforcing that we just had quality time together. But as we know, everybody is different with what motivates them. Some of us are motivated by food. Some of us are motivated by money. Some of us are motivated by social connection. And so when we're thinking of reinforcement and we want to see more, we're trying to make some change with behavior, the rule is just kind of going with whatever is reinforcing to that child, whatever they actually enjoy and makes them feel good, because that's how they're gonna feel rewarded. And you can imagine like if you were working really hard and then someone gave you like a Milky Way as a reinforcement. I do not like Milky Ways. So very quickly that would get old, right? But if somebody handed me a Hershey's bar after I did something, I'd be pretty excited because I love Hershey bars, right? So we want to figure out like what is motivating to your child and how can we use that as a reward. Children are, have to be motivated in order to do hard things. And it is hard to change behavior, but we're the same way, right? We have to be motivated as well. So it's about finding what it is that's going to keep your child motivated. We also get this a lot from parents that reinforcements are kind of losing their appeal. So Skittles used to work, or going for a walk used to be really fun for my child, but now they're not as into it anymore. And that is super common, that things that are reinforcing need to be varied up. We need some variety, right? So, an example is when I have ice cream at night, maybe one night and then 2 nights in a row, it's really good. By the 5th, 6th night in a row, I'm kind of tired of it. But if we did, ice cream and then we played a game and then we, watched a movie together, like all those things kind of keep me motivated in a different way. So we want to always have a menu of options of things that we can do. And if something is not reinforcing anymore, that doesn't mean the system has failed. It just means let's get creative and figure out something else that might be exciting at this point. And then lastly, the need for reinforcement is going to depend on how difficult the task is and how motivated the child is. So we always want the reward to match the amount of work that we're requiring of our child. So if I had to get a root canal, for instance, and someone was like, if you get a root canal, I will give you 3 Skittles. I would laugh in that person's face, and there's no way I'm getting a root canal for that because the reward does not match how unpleasant the experience is, right? But if somebody says, hey, I'll give you $10,000 if you get a root canal, well, now, I'm kind of happily heading towards the root canal. But vice versa, right? It would also be very unusual if someone gave you $1 million for waking up in the morning. It'd be awesome, but unusual, right? And may not fit the task. So we really want that level of reward to match how hard what we're doing, what we're asking our child to do is. And sometimes if we feel like our child is not motivated, sometimes we have to up the reward. So a good example is toilet training a lot of times. Sometimes because that can be a really hard process, we might start with some smaller rewards like an M&M. But if our child's being super stubborn about that, we might want to up the reward just for a limited amount of time so that we can get some traction on this very difficult behavior. Our other piece about behavior is thinking about the function behind it. So all behaviors serve a function. They happen for a reason, right? Most people do not, just hit or cry or scream, for no reason. Usually there's something that is reinforcing that, or there's a reason why we're doing it. And we'll kind of jump into that. But helping to identify why that behavior occurs can be huge because then we can work on modifying it appropriately. So when we're identifying the reason, we have 5 possible reasons here. First is medical, second is escape, third is attention, fourth is tangible, and fifth is sensory. So medical is going to be any medical concern that may be happening. So a great example is a child is banging their head and they have a headache, right? So you can imagine if we were trying to do if we didn't know that they had a headache, maybe we are ignoring the behavior or we're punishing the behavior in some way, that would be horrible, right? Because we're kind of missing that underlying medical concern that really needs to be addressed. So medical is the first thing we want to look at and make sure that we're ruling out. Escape is trying to get out of a situation, and we'll go through these in more detail, but it's basically that idea that, you were asked to clean your room and you don't want to do that. So you're going to try to get out of it. Attention is we want that attention. So for a lot of kids, any attention is good attention. It's kind of like publicity, right? So it doesn't matter, if you're yelling at them or if you're giving them a high five and saying you're super proud of them. Sometimes that can just feel like, hey, I'm getting my caregiver's attention. They're looking at me, they're paying attention to me, and that can feel good. So we'll talk about that a little more. Tangible is just getting something you want. So you really want that iPad, you really want that piece of food, you really want that dessert. It's just anything that is like a material good that you want to get. And then sensory is this feels good, right? So sometimes kids might sing really loud because they like the sound of it, like it feels good to them. And this is not always a problem, right? Sometimes sensory things can feel good and we can just let that be. But there are times where maybe a child is banging their head repetitively because they like that feeling and that contact. And that's something that we want to think about finding a more safe replacement for. So as I was saying, we always want to make sure there's no medical cause for behavior before we move on to the other functions. And so a lot of times we might see kids like hurting their head, maybe hurting the body part that is hurting. So like banging their leg or hitting their stomach. And that's something we always want to be really cautious of, is thinking about, is there a medical concern that we need to address that isn't being communicated right now? Escape is going to be engaging in a behavior so that the individual can get away from or avoid the activity. So as we were talking about, I don't want to clean my room. I don't want to do my homework. I don't want to get in the car. And some examples of this would be aggressive behavior when we're approached with a difficult task. So maybe we do okay with, letters, but as soon as we get to trying to put together a string of letters into a word, we see some aggression happen. The task is getting harder. This can also be crying when it's time to get on the bus, maybe because the bus is too loud. So you're trying to escape that situation. And then spitting out food. So food is removed from the table. So you're trying to escape having to eat dinner. Okay. Um, so one of the things that we can think about with escape is this an example of can't do or won't do? Because there are a lot of times where maybe the task is too difficult that we're asking. And in that case, it makes sense that our child's trying to escape it, right? And we might want to think about modifying the task to be a little better. So things that your child, won't do, that's more motivation related. So we want to work on compliance training, like teaching them how to comply with different commands, usually very low level and easy commands first, and then reinforcing them a lot for doing that. So if your child is not motivated to clean their room on their own, how can we reinforce them for doing that so that it doesn't matter whether they're motivated to clean their room? What they're motivated for is earning, that allowance or that extra screen time once they do that skill. If it's a task that our child cannot do, it might be out of their range just yet. And it's more of a skill deficit at this point in time. We want to think about how can we break it down more and how can we maybe prompt them with smaller steps. So a great example is, rather than saying, let's go clean your room, we can say, let's clean your room together. You pick up the red blocks and I will pick up the stuffed animals over here. So you're kind of breaking it down and then you would try to build up to cleaning that whole room. Questions we want to ask ourselves is, what is the child escaping? Is the demand too challenging? Is the demand too boring? Is the demand centered around non-preferred materials? Is the demand associated with a certain type of stimulation? Is the demand social? Is it specific to a certain person? And does the demand go on for too long? So essentially what we're trying to figure out is, what is our child trying to escape and why? Like, why is this so aversive for them to engage in? So is it too hard? Is this just boring and could we make it more fun or could we make it shorter? Is it social and my child is socialed out right now because they've been at school all day? Is this a situation where, when one caregiver gives the demand, it's really upsetting, but when the other caregiver gives the command, it's not as upsetting? Can we modify who's giving the command? And then does it go on for too long? So we often see these power struggles where, the child's maybe not cleaning their room, for 20 minutes, and then it turns into a whole evening thing. And now we've lost kind of our whole evening of enjoyment. So we really want to think about how can we kind of shorten that demand and make it not kind of derail the whole evening. So we want to really look at that task and think, is it just right? Is it really within their developmental level to be able to complete this right now? Is the environment conducive to them being able to complete this, or do we need to modify some things? Could we give some breaks before the behavior occurs? So a lot of times homework is a great example where maybe your child gets home from school and you try to jump into homework and then you notice you're having behaviors every time. Well, that would be a good cue that maybe we could give, a snack break after school and try again. So sometimes if we can track when the behaviors are occurring, we could put a break in ahead of time. Ideally, that is going to happen before the behavior occurs because we don't necessarily want to teach that because your child is engaging in a behavior or being aggressive, that they get the break, right? Instead, we want to put those in preemptively, have planned breaks that can help prevent behaviors from escalating. We can also teach our children to ask for a break or help. This can be a hard skill because usually kids are going to ask for a break every time. I know that's what I would do at work if someone was trying to, give me break options and teach me to ask for more breaks. But at the beginning, you just want to reinforce them for asking for a break. And if they do ask for it, you would say, yes, let's do the break. Great job asking. But then we can fade that out and make it more structured. But the idea is that sometimes our kids do need a break, and that's a great coping skill. And we do that all the time, right? When we're mad, we take a couple deep breaths, we maybe go for a quick walk and come back to the situation. So we're trying to build that same coping skill for our kids. Like we were kind of talking about before, starting small and gradually increasing demands. So we want to reinforce every step of the way. If we're trying to teach laundry, we first want to start with, teaching to pick up your clothes from the floor. And then that gets reinforced, right? And then next we're reinforcing putting our clothes into the laundry bin. Then we're reinforcing putting the clothes from the laundry bin into the laundry machine, right? So we kind of go step by step. And then try to put it all together. But we definitely start small and celebrate those little wins along the way. And then teaching coping strategies for situations that are unavoidable. So we all have things that we have to do that we would rather escape, but we can't. So my root canal, for instance, sometimes it stinks, but we just have to do it, right? And a lot of times this comes into play with school. Kids don't want to go to school. And it does stink. It stinks to wake up in the morning. It's hard to get on the bus, but we have to teach some coping strategies because there are some things in life that are unavoidable. So it's kind of that combo of let's modify and then let's also teach coping. If attention is the function of the behavior, this is when, your child might be acting out to get that feedback. Like I was saying, either positive or negative. And this can include a lot of things from parents. So it can include just looking at them. It can include verbally responding to them, physically reacting to them or coming over to them. So these pretty much anything that kind of draws your eye is going to count as what they're looking for with attention seeking. And even, our yelling and maybe our frustration or exasperation, that can still be reinforcing to them. So what we want to think about with this is treating our attention as a light switch. So when our child is doing something that we want to see more of, we want to flood them with attention. And, that light switch is fully on. We are all theirs. We're zoned in on them. And then when our child is doing something to get our attention that we don't want to see, we want to ignore that as much as possible, avoid eye contact, potentially leave the room if it's safe, just kind of look away, pretend like you're busy. So a good example of this would be like whining. If we hear a lot of whining, just kind of shutting down and letting your child know that the light switch is off. That's not what's going to get their attention. We can ask kind of some different questions, like let's say your child might be engaging in a behavior in a big group. You can think about like what kind of attention are they looking for? Is it a certain person's attention? Is it high intensity and attention? Do they want everybody to get kind of loud and excited, or do they want undivided attention? What is it that they're kind of going for in this situation? How we can respond when we notice that our child is trying to seek our attention through their behaviors. Another great example would be as soon as you start talking on the phone, your child starts screaming. That is a really good indicator of attention seeking behavior, right? Because your attention is somewhere else right now, and then your child is wanting their turn to have your attention back on them. So we want to teach our children to request attention appropriately. So reinforcing them when they, come over and give you a hug or something like that. Any behavior they're doing that is getting your attention, that you're excited about, that you want to see more of. We also want to teach them how to engage in independent activities. So while you're doing something else, while you're cooking dinner, teaching them how to enjoy, playing with a toy on their own, and then really reinforcing them for that. Thank you so much for playing so quietly over here while I cooked dinner. That was so helpful for me, that kind of thing. We also want to provide a lot of frequent positive interaction. So sometimes kids, it is the easiest thing to do where we're busy and we're running from thing to thing, and we just don't necessarily have a lot of time to give our children, intense positive feedback. But having those positive interactions where your child knows that they have your sustained attention that isn't going anywhere, that can just be so rewarding for them, and then make it less likely that they might be kind of seeking that out in other ways. And really, just like the light switch thing, using your attention as a reward. Your children love your attention. That's just like they love it. And so really showing them that you want to give them that too, and you love those opportunities with them, but that we want to be requesting it in the right way. We want to avoid like verbal reprimands in this situation. So even saying like, stop doing that, no, don't do that, is still providing attention to the child. But what we can do is tell them what to do instead. So if the child's kicking the back of your seat in the car, rather than saying, stop kicking my seat, or no, don't kick my seat, just say, like we can say instead, please keep your feet on your chair, or something like that. Or a good example, when your child's running through the hall, instead of saying no running or stop running, saying walking feet instead, right? So you're telling them what it is that you want them to do. We also want to use a neutral tone and avoid overreacting. So our reactions, the bigger they are, the more attention that's giving, for better or for worse. So instead, we really just almost want to think of ourselves as a blank slate in these situations, and use that neutral tone. But I think a really key thing to think about here, because I know it can be hard when we're thinking about ignoring behaviors, this is a good skill for when the behavior is minor. It's just like, it's not hurting anybody. It's something that we can ignore and it would be fine. So that's why I'm thinking about whining, even, when we think about those tantrums, where your child is just having a bit of a meltdown, but they're not hurting anybody, they're not hurting themselves, they will recover in a couple minutes. Those are some good opportunities to treat your attention like a light switch and ignore the behavior. Not ignoring your child, but ignoring the behavior. So some more examples would be crying, whining, screaming, negative statements. Sometimes as kids get older, like awkward, like inappropriate jokes kind of thing, that can just be like okay, I'm not going to attend to that kind of thing. And really just thinking about when your child is looking for that reaction from you, when they're looking to see how you will react. Differential attention, we've talked about a little bit. This is used in conjunction with planned ignoring. So when we are trying to change a behavior, let's say we're trying to change screaming. We want to try to ignore screaming when it's happening, but on the counter side, we want to really up our praise for any time that screaming is not happening. So just talking to them about, oh my gosh, thank you so much for using your inside voice. I'm having so much fun with you. Look at what we're doing together. Just really upping that praise. And the idea is trying to really catch your child being good. So we all fall into this all the time, with our significant others at home. They do the dishes and we just let it go by. We don't say anything, right? But if we're really trying to pay attention and call out all those behaviors that we really appreciate and would love to see more of, it can really go a long way in increasing good, appropriate behaviors. So calling that out, thank you so much for doing the dishes. I really appreciate you. But especially if we're thinking about a specific behavior problem that we're trying to avoid, like aggression. Well, let's make sure that we are praising so much and almost over the top when our child's not being aggressive, because that will help kind of decrease that behavior over time. Trying to make our praise as specific and enthusiastic as possible is fantastic, but also thinking about what your child likes. So some kids like nonverbal positive attention. They like that high five, they like the hug, they like the fist bump or just a big smile. And other kids really want that, positive, like, jumping up and down, giving them that positive feedback that they're doing great. So just kind of thinking about what your child would enjoy. Things to just keep in mind, you are ignoring the behavior, not your child. So a lot of people think like, oh, I wouldn't want to ignore my child. And I totally agree with that. but we just want to ignore that behavior that they're engaging in. Once you start ignoring, you have to keep that going until the behavior stops. So it can be really difficult to kind of ride out a tantrum, especially maybe if we're in public or something like that. But we really want to hold our ground on ignoring, because the last thing we want to do is teach our child that if they keep tantruming, for 20 minutes, then they will get our attention, right? We really want to hold out and be able to give that attention when the tantrum ended. Something to be aware of is the extinction burst that can happen when we do this. So your child is very used to getting your attention. There's a reason they develop this behavior. It's because it works. So when you start ignoring that behavior, they're probably going to ramp it up to see if they can get a reaction from you, because they're going to be confused on why it's not working. So my big example with this that I love is when you think about riding an elevator that you ride to work every single day, and you walk up to that elevator and one day it's not working, you press the button, it doesn't come. Are you going to calmly go ahead and walk to the stairs and just find another route to get up? Or are you going to go ahead and press that button at least 10 times and see if maybe it missed something, right? That's what most of us are going to do. We're going to kind of bang on the button to see if we can get it, and then we'll think about going to the stairs. And it's the same idea where if that same button is worked every day, they're going to press it, and then they're going to wonder why it's not working to get your attention, and they're going to press it a bunch of times again. But we want to ride that out and know that, behaviors might get slightly ramped up before they get better, but that eventually they will extinguish. Tangible is going to be trying to get what we want. So these would be examples of this would be hitting when someone has the toy that you want, having a tantrum when you're told it's time to stop swinging, crying to obtain access to the iPad, and aggression when requesting a specific snack, or when being told no for something that they want, like a food or just like a material item. So to assess this, we want to think about what are the activities and behaviors that our child is trying to get access to. Does it occur when it's time to give up access? So does it happen every time when we take the iPad before bed? Does it occur when your child needs to wait? So we're going to have dinner first and then you can have dessert, and that's when we see the behavior problem come. Does it occur when your child needs to share? They have their favorite toy and then sister comes over and takes that toy. Is that when we see the problem? Or is it when we're taking turns, with friends on the playground? What we can do to help with this is we want to avoid giving our child the preferred items following the problem behavior. So we don't want to, give the child the iPad back if they're showing problem behaviors, because we don't want to reinforce that those behaviors are what's going to get the iPad, right? Instead, we really want to ride it out, and oftentimes just removing it from the situation is the best idea. So the iPad is not an option now. It's in dad's room and the door is closed. So we're not even having to look at it, kind of thing. If it's not available, we can indicate when it will be available. So iPad time is done for tonight, but we can have the iPad again tomorrow. Remind your child what they're working for before the problem behavior occurs. So let's say we're doing homework and your child wants to watch TV. You can say, first we're doing homework and then we get TV. So you're reminding them, when they're going to get access. We can also use visual supports and timers to help our kids understand when they might get that reward. So showing them a visual timer that's actually counting down those minutes so they can see that after working for 10 minutes, then they get some iPad time, or then they get a preferred snack. Or we can show them a little chart. Once we do items 1, 2, and 3, and they can check them off or rip them off, then we get iPad time, or then we get chocolate. We also want to be mindful of the sequence of activities. So a lot of times we might accidentally give our reinforcers too early, and then we don't have any leverage or anything to grab later. So we can think about structuring, let's do non-preferred things first, followed by preferred things. Kind of a first then board. So thinking about first, let's go to work, and then we can go to the pool, kind of thing. And then lastly, we can teach children to request and how to wait for those items. So we can, teach that with different cards, like teaching them, if they want the iPad, then they can give you this card that's requesting the iPad. And this is the same concept where at the beginning, we just want to give them the iPad every time so that they get reinforced for requesting in general. But then we're going to fade that out and not let the request happen every single time. Let me just double check. Okay, I'm almost done with my section here. Sorry about that. Just want to make sure we're good on time. The last one is going to be sensory. So for sensory, our child might display different behaviors for a sensory stimulation because it feels good. So thinking about hearing that loud sound or having that feeling of kind of pressure or hitting your head on something. So an example would be your child repeatedly crashes their body into the floor or onto the couch because it feels good. Sometimes our children may need time to engage in this behavior. And like I was saying before, if it's not a problem, that's totally fine. I love laying under weighted blankets. I could do that all day, so if that's something that is just soothing to your child, we don't have to change it. But if there's a behavior that is getting in the way or causing your child harm, then we want to think about working on changing it. Sometimes your child might be doing this to escape or avoid tasks. So thinking about like pacing, for instance, like are we running up and down the hallways because we're trying to get out of something? It also may just be play-based as well. It may be something that's fun. And your child might get frustrated if the behavior is interrupted. So we want to think about, what is our child telling us that they need here? And then how can we help them identify an appropriate time and a place for the behavior? So sometimes it's not that the sensory behavior is a problem. It's just that we can't do it all the time. We can do it, in certain places or at certain times. We can also teach more play and leisure skills. So sometimes we just are engaging in sensory seeking behaviors because we're bored or we don't have anything else to do, right? So if we can limit the downtime that we're giving and teach play skills and fun activities that we can do together, that can help just decrease the amount of time that we have to engage in the sensory seeking behavior. We can also find appropriate alternatives that provide similar sensations. So if we think about like maybe chewing on the shirt, is there that, and your child's chewing through their clothes, is there something else that we could replace it with that still feels good to chew on but isn't gonna chew through our shirt? And then lastly, just kind of redirecting to those appropriate alternatives and then reinforcing for engaging in those. So giving a lot of praise when we're able to transition to different activity. So just kind of putting this all together, we want to figure out what is our child trying to communicate? What is the function of that behavior? We want to be as predictable and consistent as possible. And we never want to take away a behavior without replacing it with a more appropriate one. So just telling someone to stop doing something is hard, but if you tell them what to do instead, that can be helpful. And then lastly, just being patient, because behavior change takes a lot of time and it can be a hard process that takes a lot of dedication, often from numerous caregivers. So just giving yourself some time and knowing that it's a worthy endeavor that we're hoping will pay off in the end. Right, we can go ahead and transition to the second part.
Hi, Lauren. I think I'm going to try to take a few of the questions that we got through your part of it. I've kind of messaged Corey, and we'll do that first, if that's okay with you, so we don't get too far from the information. Is that okay? I've been trying to keep track of things here, and so we're going to go from beginning to end. But one of the family members put in that their son is having a hard time understanding if he can't fix something right then. She tries to explain it, they can't fix it, and then he has a fit. So how should that be handled?
That's a great question. And it is a hard one. I think one thing I would think about is just trying to help your child request help as much as possible and maybe pairing that with a visual timer. So sometimes like a help card can be good, and you want to first be playing like right next to them for the item that broke or that's like not getting fixed soon enough. Um, and then as soon as you notice them having a hard time, prompt them to give you the card. And over time, if they keep giving you the help card, you can, be really excited and reinforce them for that. But maybe also pairing it with a visual timer to let them know that once they ask for help, it's going to take, 10 minutes to figure it out. I think those are some things I might think about trying.
Okay, thank you. In addition, we had a question, really, and I think both of you might be able to tap into this, but how do they get their medical providers to really understand them and the stories they're sharing? They feel like it's hard to get them to listen. The child's currently in ABA therapy and on several medications, and the med list keeps growing, and they're 10 years old. And it's just getting to the point that the older she gets, the more aggression they're having. And so I think Corey might tap into more of this, but what is your thought on that?
Yeah. Yeah, I know it's really hard to find like a provider that really knows your child well. I think, yeah, Corey can definitely speak about the psychiatry piece. I know from psychology, it can take some time, but once you get hooked up with somebody that their specialty is behavior, sometimes those would be at like the closest children's hospital. And you want to think about someone that would have the availability to follow you over time so that they can get to know your child. But generally, we see a lot of gains when we can work with a family over time, crack these behaviors. So everything we were talking about today involves like sending home data for the parent to collect. What are your child's triggers? How did you respond? And how can we intervene? Which can generally take some time, like working one-on-one with a provider. So I would kind of look for someone like that, with a psychologist or an ABA therapist that has that expertise. But I know that can be hard, especially as kids are getting older.
Okay, just real quick. Child that suffers with anxiety doesn't want to go anywhere, can't tolerate other children and noise. When he hears music, he freezes and gets stuck on the spot and can't move and becomes aggressive. Their world has become very small. At school, he's in a room by himself. And if he hears other children with challenging behavior, he gets aggressive and acts out. She's just feeling sorry for him and she doesn't know how to move forward.
Totally. Yeah, that is also super hard. I think couple of things. So again, I think a psychologist could be super helpful if you're able to get connected with anybody. I think things we want to think about with that would be modifying the environment as much as possible. So can we get maybe some headphones or something that can help decrease like the overstimulation that your child is feeling? And then from there, with anxiety, we want to think about kind of taking things in small steps. So when we do anxiety treatment, we do a lot of exposures where we are starting with a really small thing. So if your child is not going outside the house, the first exposure would be like walking down the stairs kind of thing. And then from there, it would be just stepping outside and then getting a lot of praise and rewards for just doing that. And we kind of build up that fear ladder until we reach some of our higher fears. But hopefully a therapist could help lead you through that as well. So you're not just trying to come up with those all on your own. But yeah, and the school sometimes has connections to somebody like that as well.
Perfect. There's a couple more, but I'm going to go ahead and give the floor to Corey and then we'll address those at the end.
Sounds great. Thanks.
Sure. Thanks, Celia. And Lauren, if you can help drive the ship a little bit, that would be awesome. So yeah, thanks guys for coming. I'm happy to be here with Lauren. So again, my background, I trained at the University of Cincinnati and then Cincinnati Children's, and then now am actually involved mostly in kind of how our family members, our loved ones, our friends with disabilities actually transition out of the children's or pediatric system and into the adult care system. So I'm working now a lot with adults, but I think this is a huge, important topic to kind of try to tackle. So we're going to talk a little bit about what the role of psychiatry plays in kind of this big puzzle, because there is a role and there is a way to kind of approach getting in front of a medical provider. So when Lauren was talking about that meets kind of mnemonic and thinking about medical things, a lot of times we think about physical medical conditions. So we think about headaches, we think about constipation, we think about pain, dental issues. So we think about physical things, but it's also important not to also forget about the psychiatric conditions that are also present or could be present and could be part of the drive for behavior. So We know that psychiatric comorbidities are really common in individuals who have disabilities and individuals who have RTS. So, and definitely more common than even the general population. Some common things that your loved ones may be experiencing or may have not yet been diagnosed with, but may be there, are things like anxiety, OCD, depression is a very real thing. There can be a various form of different tics and tic disorders. And then also we can see those really severe things like aggression and self-injury. And it can be hard to try to tease out, is there one of these things that are also driving some of these behaviors? Go ahead, next slide. Awesome, thank you. We also know that the prevalence of psychiatric symptoms actually increase with age. So that's something to really be aware of as we're kind of getting into that transitional age and getting kind of into adulthood. Um, Individuals kind of in their teens are found to have higher rates of depression, anxiety, OCD. Also, there's some evidence that aggression and self-injury can worsen with age, but of course, that is not everyone. Some people even have the opposite effect, where the self-injury and the aggression improve with age. But so really can go in either way. There's also a pretty high prevalence of autism spectrum characteristics that can happen with RTS. Doesn't necessarily mean your child may fit the definition of autism, but there still can be some of those characteristics, like those preference for really strict routines. Like we already even talked about this one a little bit, difficulty with loud noises, new noises, crowds. We can see those kind of stereotyped repetitive behaviors. All of those could be part of just their underlying developmental condition. For some people, those cause problems, and those can actually be triggers for behaviors and can be stressors. Other times, some of these things are actually self-stemming or soothing behaviors that they engage with. So again, you got to really try to think about what's driving some of these things. But there may not be an answer, and we can't always identify triggers, no matter how hard we really try. So why is psychiatric care difficult in our patients, our friends, our families? Part of it is the association with potentially an underlying intellectual disability. We know that varying cognitive abilities can really limit a psychiatrist's or even any medical provider's ability to make accurate diagnoses. I think you guys know your children the best, and it's easy for them to stump you. It's even easier really for them to stump us when we don't have such a close relationship with them. So it can be very, very challenging. Individuals, with varying degrees of disabilities may have difficulty asking questions or understanding really questions that are really abstract and kind of like depressed. Do you understand what depressed means? Anxious, what does that actually mean? So you have to kind of tailor your wording to kind of the developmental age of the person that you're seeing or the person that you're talking to. There's also a tendency for some individuals to please. There's a lot of people pleasers, quote unquote people pleasers, that will say yes to a lot of things or say no to a lot of things when really it's not an accurate representation of how they truly feel or how they would answer the question. It's really common that psychiatric diagnoses can present atypically in this population, which can also make it very challenging for most providers, for all providers. Um, and again, we got to remember and we got to be reminding our clinicians and our psychiatrists that we should be looking at people and looking at different symptoms, all related to their developmental age, because developmental age, even more so than chronologic age, is so important when we're trying to figure out, is there psychiatric disease present, and what's quote unquote appropriate and what is quote unquote abnormal, and how can we appropriately kind of intervene to improve things. Next slide, Lauren. Thank you. So this is very similar to kind of the meats thing. For me as a psychiatrist, a lot of things that I deal with are around that kind of agitation and self-injury. So kind of out of those mild and moderate behaviors that Lauren was helping you kind of think through and kind of work on different strategies for. So I see a lot of people who are really moved into those really severe or behaviors. And that doesn't mean you can't or shouldn't be working on that other stuff. You still should be using those behavioral techniques to try to adapt or extinguish or change behaviors. But also when the behaviors get really severe, that's when the potential for some help from psychiatry or medical doctors or even medications can be helpful. And when I'm approaching it, kind of very much like the meats mnemonic, I'm thinking really in these big three categories. So what is driving these behaviors? What is driving this agitation? There's a reason. They're trying to communicate something to me. Is it a medical something, a physical medical something? Is there something in their environment that is causing stress or is causing distress? That is kind of the antecedent for these behaviors, or is it a true underlying psychiatric condition? And we know those are prevalent. Next slide. So medical things that we're thinking about and things that you as family should be thinking about and your provider should be thinking about, common medical things can really cause problems and cause escalations of behaviors. Common things, because you or I may be able to say that something hurts or something's bothering them or something's different, something's wrong, but not everyone has that same language skill or that same communication ability. So if we're not able to say that, we may be seeing that communication be expressed in other ways like agitation or aggression. So thinking through, okay, is there something medically wrong? Is there a dental issue? Or has their sleep been really off for the past couple of days? Are they constipated? Is there some infection? Seizure disorders, pain, hearing, vision changes. There's a whole list, but making sure that we are thinking through the medical things, and you guys as primary caregivers that know your kids best are really advocating for your physicians and your to really think through this, especially if you're noticing some change, even though even though it could be a really small change. So say Johnny typically goes to the bathroom every other day, but it's been 2 days and now we're seeing worsening behaviors. That may be a big enough change for Johnny to kind of trigger some unwanted or maladaptive behaviors. Next slide. Environmental things, and these are things that Lauren really talks about and talks about really well, and things that sometimes if you can identify the trigger, you can kind of intervene and kind of change either that antecedent or that kind of consequence. But yeah, don't forget about that living environment and seeing how that could play a role. So noise, volume, temperature, lighting, any changes to their routine, and that could be very, very small changes, that could be very large changes, but some people are very, very sensitive to that. Changes of or the loss of important people in their life. That could be family, caregivers, staff, teachers, peers. Those all can be potentially social or environmental triggers for worsening behaviors. Loneliness, social isolation, boredom, a sense of a lack of control or a sense of a lack of choice. These are all things that we as providers should be thinking about, and as we kind of trying to figure out how can we best help your child or help the person in front of us. Next slide. And then the big one, and usually while I get kind of pulled into the conversations and pulled into treatment and care, is when there is concern that outside of the environment, outside of medicine, there is some psychiatric factor that may be contributing. We know that psychiatric conditions are underdiagnosed in in our population in RTS and all disabilities really, and we also know that it's very common that they're misdiagnosed. And that could be for many, many reasons. Either, as physicians and psychiatrists, we don't really get trained uh, in through our medical school and through our residency on a lot on how to approach individuals with different disabilities or how to adjust treatment to kind of accommodate those disabilities. So there may just be a lack of training um, or understanding, which can be really, really challenging. Um, but the common things that we see, or those we already talked about. So really the key to improving symptoms, as Lauren talked about before, is really to identify and treat the underlying cause of that symptom or that kind of behavior. And for some things, for those mild to mild, moderate things, you're really leaning heavily on your behavioral strategies, but there are also a period of time when things get really severe or when there can really be no identified trigger or antecedent to the behavior that we got to think, okay, is a psychiatric condition the actual underlying cause that we need to address? Next slide. So psychopharmacology, so medication. So I think my goal is always I want my patients, your family to be on the least medications possible, but the least medications that allow them to function and allow them to enjoy things and allow them to engage kind of in a routine that is fulfilling to them. And that can be challenging. And a lot of it, to be honest, is depending on the physician, it can be some trial and error. Ooh, I think this may be some anxiety. I think this may be OCD. We need to try medicines for that to see if it works. Or is this depression? Can we try medicines to help that? So there may be some trial and error involved. But the thing to remember when you're talking to your physician about medications is that idea that we want the least medications possible. And that means if we are making adjustments and we are trying to address symptoms by adding things, we should be talking through, okay, are there things that we can then decrease? Or are there things that we can then wean off of since they may not be working? So, because unfortunately, the reality is a lot of times medications just continue to get added to try to treat the symptom, and we never actually get to that underlying cause or that underlying kind of trigger. And it is very common. I mean, you see 30% of individuals with disabilities in RTS are on 10 plus medications. That's a huge number, specifically, especially compared to the normal population or the general population who are on much lower. So there is medications out there that can be helpful, and they're specifically helpful when those behaviors are pretty severe and extreme, and when they are causing risk of harm to your child or the patient, or to the family, caregiver, staff that's working with them. So that's when really we got to be thinking about, okay, are there opportunities to use medication to help with that behavioral work that we're doing? I'm not going to go through specifics of these medications, but there are medications out there that have been studied and been studied well, and that have been shown to work for different conditions with people who have different disabilities, including RTS. So there are things out there that have worked, but again, everyone is so individual and so specific to them that it may take some trial and error to figure out what is the appropriate combination of meds or the appropriate single med that may work for your child to kind of help with the behavior. And again, the aggression, the agitation, the medicine in and of itself is usually not enough. It has to be paired with some of those behavioral interventions and that behavioral work to really help mitigate the continuation of the behavior and decrease the severity. So I would avoid people who are just trying to cover up the symptoms, because you got to target that underlying behavior, which is really what Lauren was kind of working through before. Next slide. So that's kind of it for my part. My part's a little smaller, but I think now Celia was probably going to ask for more questions and we can try to help. I think, remember, it definitely is hard for Lauren and I to give specific recommendations for, really specific without knowing your children and not being able to see them, examine them. But I think giving some broad recommendations and kind of help working through things is definitely things that we could do in this kind of context.
Corey, one that came up just as you started speaking, and I think both of you can speak to it, and actually some of the parents reached out too, is that somebody placed in the chat, my daughter is nonverbal and very delayed. She's 3 and sometimes she just cries and cries for no reason. She also wakes up and just cries for hours at the night. She doesn't understand sign or how to communicate with us. How do we figure out what's wrong?
Lauren, you want to take that one first?
Yeah, I think one of the first things I would think about is a medical rule out. You might have already done that totally, but just thinking about if there's anything going on that is leading to the crying, like any pain they might be in. But otherwise, I know sleep can be a really difficult thing for kids to work on, and there are quite a few books that talk through helping with sleep for kids with developmental disabilities, but generally we can think about like going in and checking on them and comforting them, and then walking out. So not necessarily like taking them out of bed, kind of thinking about sleep training. But that was one of the things that came to mind. I don't know, Corey, did you have any thoughts on that one?
Yeah, no, I think that's good stuff. And also just seeing, are there ways that you can adapt the environment around them? So is it that your child wakes up in the middle of the night, all the lights are off, the door is shut, they for the moment in that, or in that kind of confused, I'm just awake space, it kind of exacerbates some of the crying. So I think, again, trial and error. Would it be helpful to have what about a nightlight? What if the door is open? Trying to modify some of those environmental things that we think of as soothing, or your child may find soothing during daytime kind of sleeping hours. So that came to mind when I'm thinking about the sleep specifically piece.
She did add in
Yeah.
the chat that the child is sleeping with them.
Oh, okay. Gotcha.
That
Sometimes I know things that have been helpful, is like a red light, green light system for families, where basically they're finding a way to indicate to their child that this is nighttime and that we're going to be sleeping. So it would be like a red light at that time. And then in the morning, you would switch it to a green light and reinforce like, oh, it's the morning, it's time to get up. So I think kind of playing around with some strategies like that, might be helpful.
Okay. The mom who had the question earlier about her son not understanding things that can't be fixed. She said he's
Yeah.
totally verbal. He's 12. She gave an example of him wanting to dress up and wear his bow tie tonight, and it ended up ending with him being upset and breaking the tie. How do they handle it when it's something that it just can't be resolved?
Oh, it can't be resolved.
Yeah, so it's one of those things. So they can buy a new one, but they can't do it at that point. It can't be fixed. It's something that there's not really a way to come to what would feel like a resolution or a good ending in that moment. And how do you
Totally.
move them
That's
along?
super hard. So I know that can be like really disappointing, for kids. I think this is kind of a longer term skill that is hard to work on. But one thing we try to teach kids is about the size of the problem. So is this a small, a medium, or a large size problem? And when we think about that, we want to think about how another person would view the problem. So not your child, because of course it feels big to them then, but you want to cue them. What size do you think the grocery store clerk would think this problem is? Or what size problem do you think our hairdresser would say this problem is? And we want to kind of help them recognize that this is a small problem. So we want to use some calm down strategies and help our reactions to match the size of the problem. So that's a skill that will take a lot of practice, because like I'm still working on doing that, but just kind of teaching that, yes, this is disappointing, but what can we do to calm down, given that there's nothing we can do to fix the situation?
So we've got just a few minutes left from you guys. For a lot of us don't live here. I want to tell Fabiola, the interpreter, that there is a question in the chat that I could not translate. And I want to make sure. Oh, thank you. Okay. No, thank you. Yeah, go ahead.
Celia,
Ilka.
there's one question that I think, because it's like multiple
This
people
one?
who have similar issues.
Sure.
So there's a question. My son will reenact a thing that hurt or upset him several times in ways that hurt him more than the actual thing that happened. I've tried to de-escalate the behavior by calming him, but most of the time I just end up having to let him follow through with his act until he feels the full injury is communicated. Does that fall under those meets categories? And then somebody else responded and said they have similar behaviors in their kid too. It was like Tabby at 7:37, if that helps.
Okay, yes.
It looks like it. Yeah.
To scroll. Okay, could you just summarize that in like so sorry, I can't find that chat.
So it was Tabby and Vanessa at 7:37. So in some ways they're redoing, so say they got hurt, they are doing this over and over again to communicate that they got hurt, but they hurt themselves even more so in the process.
Oh, I see. Yeah.
And what do you do when that happens? Even it sounds like the parent tried to kind of de-escalate, but it's kind of hard to get there.
Totally. Yeah, that's really hard. So one thing I would try to do, if this behavior keeps happening, is try to like kind of like the help card teach them to get comfort from you when they're not actually hurt. So like practice kind of bonking your leg and then pointing to it, and then mom gives it a kiss or something like that. Like kind of practice teaching them that process, that when we hurt ourselves, we can come over and get comfort. I think the other thing that is hard, because they're probably just like in pain, and so then they might be de-escalated and kind of engaging in something that is going to hurt them more. So I would just try to keep the environment as safe as possible. Like we have some of those pads with us where we can kind of like put the pad in front of the window so that our child's not banging their head on the window. So kind of like prevent that behavior from hurting themselves more and kind of ride it out. So I would try a combo of those two things. Like in the moment, just try to keep them safe as much as possible physically with like comfortable pads and things like that. And then outside of that time, try to teach them that they can come to you for comfort and you'll help them with a Band-Aid or whatever it is.
Okay, we're pretty close to our.
I'm so sorry, Celia. There's
No, go
another
ahead.
one in the chat for Corey, I think.
I missed it.
You alluded to that, Corey, but there are a couple of parents who essentially say, how do we get a doctor to understand us? My kid gets more and more meds, but the behaviors get worse. It's not working. And so now you have a kid that is like on 9 medications at 10 years old, but the behaviors are not getting better.
Yeah, I think it's a huge challenge and very common. I think the best thing that we can do, obviously, if you're in an area where they do have specialty care, so you have, specific specialists within, a children's hospital, et cetera, that's always a great place to try to find some help and be seen. But I know that a lot of us are not. So I think to the best of our ability, really trying to relay the idea that you definitely, your child best, and you know what has worked or what has not worked, and really being pretty thinking through, okay, and talking through, if I'm going to start something else, can we look at these other things that haven't been working, and can we start to decrease, and coming up with a plan to, sure, they may not want to do it the same day, but okay, let's increase this thing. When we come back in 2 weeks to check in, the plan is to decrease this thing, and to really encourage and ask to come up with some of those plans, because as we're adding new things, a lot of things could be weaned or taken off. Other times, if there are periods of time where your child is doing well and people are doing well, looking back at the medications and thinking, okay, are there any of these that we think actually were not helpful or can be taken off? So using opportunities like that to try to the best of our ability, reduce that overall med burden. But it's a huge challenge. There are some doctors that really appreciate, because for a lot of times you probably know more about RTS than any of the doctors that you're going to see. So some will appreciate if you know things, to give them information like, hey, I know I read about this, or this is something that I heard about, or this is one of my, my support groups we talked about. Some people really respond well to that. You may find doctors that don't. And honestly, if you have a doctor that doesn't respond well to that, that may not be the best doctor for you anyway. So using your knowledge base to kind of really help drive some of those decisions, because you know more probably than most doctors.